I've been in emergency medicine for approximately 30 years, and during that time I've treated hundreds of patients who've come to the ED either seeking a prescription refill for a controlled substance or requesting to be treated in the ED with a controlled substance. Many of those patients are legitimate and many are not.
I was kind of the person who would be the candy man. I was trained to, I'd rather treat 10 people who were drug seeking and faking their symptoms rather than deny one patient who's truly in pain, because that was kind of the rationale.
Some patients who use the ER for their chronic pain consume a lot of resources. They escalate their demands. They switch their complaints in the middle of visits.
It's hard when you see someone for the first time to know if they're legitimate or not, to put it bluntly.
The nurses feel like, once again, the emergency room doctors are just willy-nilly giving these patients medications, that the patients are not assuming any responsibility for trying to use other methods to solve their pain other than just seeking narcotics. And it feels like we're setting up a society of addicts, and that we're really, in fact, kind of the gatekeepers of that. And that's not what we signed up for.
There's a sense of relief because the parameters are there, and you know that they can try to con you, they can try to manipulate you. You have this that's on their side. I mean, it really is on their side. It's on our side too, but it's on their side because it protects them.
Having spoken with Dr. Suzanne Johnson about her program at Alameda Emergency Department, it was clear that this was probably a better way to deal with these patients. Better for the ED, better for the hospital, and most importantly, better for the patient.
The program has kind of showed us that it's okay to say no.
I think having the care plan in place makes for a better environment for everyone, not just the nurses, not just the patients or the doctors, but all of us as a whole.
And it makes me feel better because now, I don't have to think about, what should I do? Is this person believable or not? I go to the care plan and, I have, an out.
Patients respond when you actually speak to them about what is in their best interest.
And I think some of these people just get really very tired of hurting and being in that vicious cycle of needing pain medicine and pain. And it's got to be a little feeling of relief, and that they have a little bit of control, or somebody else is helping them to help corral their life a little bit better.
Having a consultant who knows the steps of the program and what it takes to implement it was invaluable.
We felt that we had an expert, somebody who has experience, somebody who has proven that the program can work in her own ED to guide us through our own implementations.
And so if you have somebody who can give you a template and kind of show you the way and have the experience to do it, it's really much easier than trying to do it from scratch.
Of course, an ED director and his staff or her staff can set up a program like this on their own, but I would not advise it.
The upfront cost will be paid back many, many times over.
To have the expertise of someone like Dr. Johnson and to have the actual program documents provided by Dr. Johnson not only saves you a lot of time, but almost guarantees that it'll be done correctly.
I think it's a movement that ultimately every hospital is going to have this, so they better get on board before they, just are overwhelmed by it.
And it provides the best patient care and consistency, which decreases risk. Whereas without the plans, you're all over the board and the patients are confused and they complain to administration. So
It is imperative that nationwide we start having care plans in the emergency room that the doctors and the nurses can look to, as they can use it as a tool to help the patients help themselves.
It's easy to sit in a meeting and have a coffee committee idea and say, yes, somebody should create a program like this. But actually doing the work and starting from ground zero, it's very labor intensive, and having someone who's done those steps, I think, saved a lot of time, was well worth the money, and will be well worth it in the future.
Would I work in an ER without a care plan? Not for long.
I don't think any ED would go back to the old way of doing things once this pain program is implemented.
Most people who've lived with them now can't live without them.